Good morning, everyone. Dear Chairman, Professor Matetsky, Professor Weinstein. First, I would like to congratulate you for having the first Israeli international meeting. You should be congratulated for that, and thanks for inviting me to speak. I'm not going to discuss the new emerging inotropes, since we truly don't have any new data, and at the same time, I'm not going to discuss digoxin, which I truly believe that has no significant place in the treatment of acute decompensated heart failure at the current time, unless new data are going to emerge. So I've been asked to talk mainly on current guidelines and which patient should we choose for inotrope treatment, when should we give inotropics, and which inotrope if we can, and what is the duration of treatment. So actually, what does the literature tell us? Actually, very little. We don't have much data, mostly not randomized, and so we have to base on what we call expert consensus. And the standard of care, as I said, is mainly based on experts or case studies, not much of a data. When we group the patients into with acute heart failure into groups, then we have three main groups. One is those who present with acute heart failure, either cardiogenic shock due to ischemic reasons, sudden decrease in blood pressure, MI, arrhythmias. The second group is those patients, very few, with end-stage advanced heart failure, with severe LV systolic dysfunction, with low cardiac output. These are mostly 5 to 10% of the patients. Then the largest group are those patients with worsening chronic heart failure with either reduced or preserved ejection fraction. So which inotropes do we have? Actually, the recent 2013 American guidelines endorsed mainly two inotropes. Surprisingly, only two. Either Dobutamine, which increases cardiac output and heart rate with mild or no effect on systemic and peripheral vascular resistance. And Dobutamine is currently actually stands as a gold standard for comparing to other inotropes, but as a drug by itself did not have any significant effect on mortality or morbidity. And the other inotrope we have is Milrinone, which we're going to discuss next. So Milrinone is a phosphodiesterase 3 enzyme inhibitor. It is a selective inhibitor. It works on the cardiac and vascular tissues, resulting in vasodilation and inotropic effects with little chronotropic effects. It requires no dose adjustment in hepatic impairment and requires renal adjustment in dose adjustment in patients with renal impairment. What do the FDA tell us about the use of Milrinone? These are the FDA approvals. Milrinone is indicated for the short term only IV treatment of patients with acute decompensated heart failure. The majority of experience with Milrinone is based on studies done in patients receiving either digoxin or diuretics, which are not current data, of course. And there is no experience in controlled trials with infusions of Milrinone for periods longer than 48 hours. So this gives us a clue for how long should we use Milrinone. What are the advantages of Milrinone over Dobutamine? It can be used concomitantly with beta blockers. As we know, the risk of death is higher in patients in whom we either discontinue or reduce the dose of beta blockers when they are admitted. And the increase in mortality is only partially explained by the worse prognostic profile of these patients. Milrinone acts independently of adrenergic receptors and is still effective despite the downregulation of beta receptor adrenergic receptors in patients with chronic heart failure. And with regard to its effect on peripheral vascular resistance, it reduces it mainly due to its phosphodiesterase inhibiting effects. Here we see that in patients who are on chronic beta blocker treatment, actually phosphodiesterase inhibitors can improve cardiac output or cardiac index, either when the patient is treated either with metoprolol or carvedilol, and it can at the same time reduce the wedge pressure and improve hemodynamics. So the International Society of Heart and Lung Transplantation Guidelines from 2006 recommends that phosphodiesterase inhibitors, mostly Milrinone, but others as well, should be used in patients with preserved systolic blood pressure, and it should be preferred over Dobutamine, especially in patients who are concomitantly treated with beta blockers. And because they act independently of androgenic receptors, they are still effective despite the downregulation of these receptors in patients with chronic heart failure. The short-term administration of these inhibitors may improve myocardial performance and clinical conditions of patients with chronic heart failure. So these are the 2006 guidelines. What are the advantages of Dobutamine over Milrinone? Where actually there are none except for the money. It's much cheaper, much cheaper. Still, Milrinone did not do well in recent studies. And this is the study we have, the OPTIME-CHF. Not a very large study, but I would say a moderate-sized study with 950 patients with acute diastolic heart failure, acute decompensated heart failure, and systolic dysfunction, who actually did not require any inotropic support. Yet they were randomized to a study in which they were giving Milrinone and placebo for 48 hours. And here are the results. The adverse event rate was 6 times higher in the Milrinone group compared to placebo. So does the sustained hypotension, 3 times higher. The acute MI rate was 4 times higher, and AFib patients was significantly higher, 3 times higher with Milrinone compared to placebo. And the mortality was also higher, not significantly, but 1.7 times higher with Milrinone compared to placebo. And if we group the patients into the ischemic and non-ischemic etiologies, we can clearly see that in those who had an ischemic etiology of heart failure, the in-hospital mortality and 60-day mortality were significantly higher. And if we lump the death and rehospitalization rate together, we can see that they are slightly higher in the Milrinone group compared to placebo. So overall, Milrinone did not do very well. So inotropes are a sword with 2 edges. They may be proarrhythmic. They probably increase mortality in ischemic patients, and they may hibernate the myocardium, who actually, as a protective mechanism, may start recruiting hibernating myocytes and may hasten cell injury or apoptosis. And the short-term gains appear to be offset by the higher mid- and long-term mortality rates. So now we have Levosimendan, which will be discussed later more thoroughly, probably by Professor Parisis. Levosimendan, so I'm going to touch briefly on it. Levosimendan is the first in a new class of calcium sensitizers. It enhances calcium sensitivity and the myofilaments by binding to troponin C and opens the ATP-dependent potassium channels in vascular smooth muscles. It has a rapid onset of action and a sustained hemodynamic response due to the active metabolite, which has a half-life of 80 hours approximately. In studies done with the Levosimendan, it significantly reduced the pulmonary wedge pressure compared to placebo, and the effect was sustained for 24 hours, and longer infusions did not do any better than a short infusion of 24 hours, as recommended currently by the drug insert. It also significantly increased the stroke volume, again, significantly compared to placebo, and the longer infusion did not do any better than a short infusion. So these are the current data, and when you compare it to Dobutamine, it increased significantly the cardiac output at 24 hours. Here Dobutamine in red and Levosimendan in blue, and you can see an increase in cardiac output, which is significant, accompanied by a reduction in pulmonary wedge pressure at 24 hours. These are the data for Dobutamine, here in red, and the blue stands for Milrinone. I'm sorry, for Levosimendan. In the little study, again, there was an increase in cardiac output, a significant increase in cardiac output, a reduction in pulmonary wedge pressure as compared to Dobutamine, with a non-significant increase in stroke volume, no increase in heart rate, and a very mild reduction in systolic blood pressure, only 3 millimeters. In the SURVIVE study, which was a mortality study, Levosimendan was compared to Dobutamine. This was a relatively moderate-sized study, 350 patients in each group. The patients were followed for 180 days. Some of our centers here in Israel took part in it, and it actually did not require any invasive monitoring. As you can see here, these were very sick patients. Most of them were in class 4 patients, 86%. The ejection fraction, the mean ejection fraction was 24%, and the BNP level was fairly high. And again, in this study, the BNP reduction with Levosimendan was significantly better than with Dobutamine. And but the all-cause mortality, actually, not the short-term one, the mid-term one, and the long-term one did not differ between Dobutamine and Levosimendan. Nevertheless, there was a trend for improvement with Levosimendan, either in all-cause mortality in the short term, or when we lump the studies on Dobutamine compared to Levosimendan together, 1,700 patients, we can see a significant reduction in mortality, in 30-day mortality, favoring Levosimendan. So the advantages of Levosimendan are due to its dual action, probably increasing contractility and increasing vasodilation. It relieves symptoms of heart failure. It may affect or maintain, may be effective in patients treated with beta blockers. It has a rapid onset of action due to its bolus, and the effects are long-lasting due to the active metabolite, which has a long half-life. It's probably not arrhythmogenic, except for those who are receiving it as a bolus, and does not increase oxygen consumption, and may have a mortality benefit. What about the duration? I will touch briefly on that. There is only one study, studies by John Paresis, who studied repeated administration of Levosimendan in patients with severe heart failure. This patient received a 24-hour infusion in 5 courses over every 3 weeks compared to placebo, and there was an improvement in the echocardiographic measurements as well as neurohormonal measurements in those who received repeated doses of Levosimendan, but this is the only study we have so far, as far as I know. So what do the current guidelines tell us? So these are the American guidelines, the 2013. They state that parenteral inotropes remain a therapeutic options for the subset of patients with heart failure who are refractory to other therapies and suffer from the consequences of end-organ hypoperfusion. Inotropes should be considered only in those patients with systolic dysfunction, have a low cardiac output or low cardiac index, and evidence of systemic hypoperfusion and or congestion. They give the inotropes a 1C indication until definitive therapy, either revascularization, mechanical circulatory support or heart transplantation, or until resolution of the acute precipitating factor or problem in patients with cardiogenic shock, and they can receive temporary IV inotropic support to maintain systemic perfusion and preserve organ performance. And they give the inotropes a 2A with a B level of evidence indication for continuous IV support may be reasonable as a bridge to therapy in patients with stage D, refractory to medical treatment or device therapy. So actually they recommend the use of inotropes as a bridge to an improvement. What about the contraindications? The long-term use of either continuous or intermittent IV parenteral positive inotropic agents in the absence of specific indications, should not be used for palliative treatment and may be potentially harmful. That's the American guidelines. What about the European guidelines? You would be surprised to find only 6 or 7 lines endorsing the use of inotropes in the recent European guidelines. And if you look at this algorithm, you will see that they should be used only in those patients who are hypotensive and do not respond fairly to other measurements or other medical measurements. So very little space for inotropes in the European guidelines. And this is what they say. There is a pharmacological rationale to use Levosimendan or a phosphodiesterase 3 inhibitor such as Milrinone or others if it is felt necessary to counteract the effects of a beta blocker. Other than that, there probably there is no space for inotropes. And lastly, the Heart Failure Society of America, with its guidelines from 2010, give a 2B indication to inotropes. They may be considered to relieve symptoms and improve end organ function in patients with reduced ejection fraction and diminished peripheral perfusion or end organ dysfunction, particularly in those with marginal systolic blood pressure, 90 millimeters of mercury or less, who are having symptoms despite adequate filling pressures and are unresponsive to or intolerant to IV vasodilators. So again, a very specific space, and this is a very important slide. There is a group of patients who are awaiting transplant, in whom it is impossible to wean them from inotropic support, and in these patients there may be a place for continuous inotropic support until recovery or any mechanical support device or heart transplantation. So what should be our recommendations for their use? They should be used mostly in those patients who have low cardiac output, those patients who are cold and wet or cold and dry, and they comprise nearly 1/3 of the patients according to recent studies. These are the only patients who should be considered for such a treatment, and for the short term they should be given due to the concern about the increased mortality. They should be given only to patients who are who do not respond fairly to other measurements, and they should not be routinely used in every patient with heart failure. The administration of an inotrope, preferably Levosimendan, should be considered in patients with hemodynamic compromise that is not adequately managed by diuretics and vasodilators. For the long-term infusion may be useful as a bridge to definitive therapy or until resolution of the acute precipitating factor, and the long-term infusion may be considered as a palliative therapy of symptom relief in selected patients with stage D heart failure. Thank you very much.